in this lecture, we're going to be taking a look at sodium and potassium. With each of the ions that we look at for this chapter, the first thing you want to be sure you understand is what is the normal role of that electrolyte in the body. Where do we get it from? How do we lose it? How do we retain it? What's the regulators for it? Those are going to be really important factors in looking at these different electrolytes. So first we need to take a look at sodium and what are its four primary roles in the body. So its job is to maintain serum osmolality. We've mentioned that before. When I say serum, I'm talking about blood and fluids. Sodium is osmotically active, and so it pulls fluids towards it. So it's an important factor in maintaining that blood volume, blood pressure, fluid volumes in other areas of the body. It's part of sodium bicarbonate, so we'll talk about its role in acid-base balance. When we say current carrying ion, we're referring to action potentials. The role sodium plays as the depolarizing ion in all muscle contractions, cardiac muscle, all action potentials and nerve functions within the body. And it's an integral role in the sodium-potassium pump because that function is to maintain cell integrity. You see here I mentioned on top here we need 500 milligrams per day. The average intake is 6 to 15 grams per day. So the U.S. diet does not have any excess or any lack of sodium in its diet, and in fact there's an excess. And so although we will talk about the role of the kidneys to retain sodium, and that is important, there's an awful lot of sodium in our urine output because of the excess taken in. Now when we look at sodium and water issues or sodium issues, we have to look at water issues as well because of that osmotic characteristic of sodium. So we're going to look at this disorders in two main categories, what we refer to as isotonic conditions and what we refer to as disproportionate or imbalance between sodium and water. The first two are fairly straightforward. When we look at isotonic fluid volume deficit, or what we can call hypovolemia, we are losing both water and sodium in equal parts, so that does not change the osmolarity or osmolality of the fluid. In other words, the osmotic pressure isn't being altered at all. This can occur in any kind of fluid loss, such as trauma, loss of GI fluids, excess urination, excessive sweating, in which both sodium and water are both being lost, and our third space accumulations, as I mentioned in the previous lecture, fluid in the pericardial, pleural, peritoneal space with ascites. Those are all areas where the fluid volume is lost. It's a hypovolemic state, but the sodium was moving in this equal amount. Manifestations, assuming it's not third space, but again it's fluid loss from something other than third space, you will see weight loss. If it's third space, the water's still on the body somewhere, so it's still going to be weight, it's just not in the right spot. Definitely there will be thirst, particularly as the condition worsens. Urine output will decrease. Your red blood cells, your hematocrit levels will increase because the concentration is increasing. So there's not more red blood cells. It's the same number that were always there, but now in relation to the fluid, it becomes concentrated. So you see an increase in hematocrit. The BUN, or blood urea nitrogen values, which is a measure of the amount of waste in the blood, that value will also increase because of the concentration of the fluids. You will see what we refer to as reduced skin turgor. There's a good picture in your book. Take a look at what I mean by skin turgor when you look at that image in the book. Eyes may appear sunken. In infants, you may see a depressed fontanelle due to the decrease in cerebral spinal fluid. Temperature regulation decreases, mucous membranes become dry, tears, salivary glands kind of decrease in function. You can see blood pressure and blood volume dropping because fluid volumes are dropping. This will result in an increase in heart rate, and that's your major diagnostic factor here. A lot of times with this fluid loss, it's hard to measure this, but we can see drops in blood volume and blood pressure and an increase in heart rate as a diagnostic tool for this. The isotonic fluid volume excess occurs more with things like kidney failure, heart failure, liver failure, our condition of Cushing's that was mentioned previously, and I didn't mention it with the isotonic fluid volume deficit. Addison's can be a condition there. So Addison's in the hypovolemia and Cushing's in the hypervolemia can be a cause. Less common but possible can be excessive sodium intake. Anesthetics can sometimes be involved in its effect on ADH. All are things that can cause this condition to occur. Manifestations are probably just about the opposite, we could say, of what we saw with isotonic fluid volume deficit. Instead of weight loss, you're going to have weight gain. There may be edema. Neck veins may appear distended or sticking out, bulging. Blood pressure and blood volume increase. Your hematocrit, your red blood cell count, and your BUN concentrations will decrease. You may have fluid start to accumulate inside the lungs. Pulmonary edema is what that would be called. So you get shortness of breath. You maybe have a productive phlegmy cough that can be associated with that. And all of your other electrolytes in this case are going to be diluted because of the excess fluid. Likewise, you will see that also happening in fluid volume deficit in the opposite way. If there is a lack of fluid, you will see all of the different ions, things other than sodium, such as your potassium, your magnesium, your phosphate. We will see all of those become concentrated. Their ratio to fluid will seem larger, whereas in the hypervolemia, they're diluted. Diagnostically, again, we're looking primarily at what we're seeing with blood pressure and blood volume. Now, the conditions in which they're not equal, the disproportionate, is going to be what we just refer to as hyponatremia, and there are several different types of hyponatremia. Now, again, what we're looking at here is a loss. Generally speaking, we're looking at loss of fluid and sodium in disproportionate amounts. It is our most common disorder. It's particularly something we see with the elderly, especially with kidney disease. Now, the first one that's listed here, the first category of hyponatremia, is referred to as hypertonic translocational hyponatremia. Please pay close attention here. I always ask about this on the exam, because this condition can be linked closely with diabetes mellitus. And so we'll talk about diabetes as we get towards the end of this course, so I want you to learn it here so when we get to the end you are already familiar with it. In this condition, what we have, the term translocational should be key. We're going to have fluid moving out of cells into the interstitial space to dilute the sodium. That's how we get hyponatremia. Now, the reason this happens is what we have is an excess of glucose. Glucose, like sodium, has osmotic characteristics, so it can pull fluid towards it. So in a patient who suffers from diabetes mellitus, they have an excess of glucose in their blood because they're lacking insulin or lacking a response to insulin, and glucose does not move into the cells. So you have an excess of glucose hanging in the extracellular space, in the interstitial space, and that's osmotically pulling water out of the cells. The osmotic shift of water comes out of the cells and dilutes the sodium that's already in the extracellular space. So the sodium level didn't actually change, but because of the translocation of water, it becomes diluted. This is crucial because what you have happening here is your cells are shrinking. That's an important factor because when cells shrink or crenate, they don't function very well. So it's a huge problem for for a patient with diabetes. Now, the other conditions are all what we would say are dilutional forms of hyponatremia. They all fall under the category of hypotonic. So, in the first one, hypovolemic, hypotonic hyponatremia. And again, like I said, there are all three of them you see have the word hypotonic in their name. In this first one, it is the most common disorder, and it is most predominantly linked with someone who has lost both sodium and water equally, but then only replaces the water. So think of someone who's exercised excessively and they sweat a lot. They ran the St. Jude Marathon, and now all they're doing is drinking water. By doing so, they dilute the sodium that remains in the body. So although they might have initially been isotonic, It becomes hypovolemic hyponatremia because they add only water back in. Now, normal volemic or euvolemic hypotonic hyponatremia is most commonly associated with this condition, syndrome of inappropriate ADH, and it is linked almost always to issues with use of anesthetics and surgery. It's a temporary condition. It usually resolves itself within 4 to 5 days of post-op. So if you're monitoring your patient closely, monitoring their sodium and water intake, you can help balance this and prevent this from becoming an actual condition of diluted sodium in the body. But it has to do with the excess ADH pulling and retaining more water, and so they have less urine output. So we really didn't take in any more water here. That's why it's euvolemic. It's the water that was already there in the body not being pushed through the kidneys as waste. Hypervolemic hypotonic hyponatremia is our least common, but it is associated with conditions of heart failure, liver disease, renal disease, and I list here abuse of ecstasy as if there's any other way to use ecstasy besides abusing it. But that's kind of how the book lists the MDMA or ecstasy can lead to very severe hyponatremia. Again, these are linked to dysfunctions with ADH, but they're not temporary necessarily. This can be heart disease, liver failure, liver disease, renal. All of these can be long-term conditions leading to long-term problems. It won't self-resolve until the condition is resolved. Manifestations for these conditions are listed in Table 8.4. Again, thinking back to what the normal function of sodium is, think about the functions of neurons in the body, and you will see that you have weakness of muscles, you have poor central nervous system functions, headaches, disorientation, weakness, seizures, coma. They're all due to decreases in the neuron activity, decreases in action potential activity, because you're lacking in insufficient sodium for depolarization. So the majority of the manifestations are all linked to the neuron functions. Cell shrinkage and problems with the cells due to failure of sodium potassium pumps can also be involved in causing some of the problems that are here. Keeping in mind, when it comes to manifestations, no patient is going to exhibit all of these. They may have only one or two. So as you're looking through them, focus not so much on trying to get a list of what these manifestations are, but thinking about what the normal function of sodium is and how that won't function correctly because there's not enough. In hypernatremia, this is a rarer condition, but it does occur. It's an increase in your plasma concentration of sodium, and it almost always leads to cellular dehydration. And if I just jump to the bottom here, this is the problem. Excess sodium in the ECF pulls water from the cells, leading to cellular dehydration. You'll have thirst, and concentrated urines are trademarks for excess sodium in the body. Causes can be dietary excess. It can be increased levels of aldosterone, so you're retaining too much sodium. It can be excessive IV administration. If you have an inability to express your thirst, you don't bring in fluids, hypodipsia, you either don't know you're thirsty, or you're an infant or disabled and you can't say that you're thirsty, and so therefore as you dehydrate, the salt levels start to concentrate. Now, euvolemic, there are some categories here. They're a little bit simpler. In euvolemic hypernatremia, water from the intracellular fluid is pulled into the ECF, and this is, I bolded it, it's the most common. In hypovolemic, water loss can be greater than sodium loss. That's possible in some cases. Or hypervolemic, and this is the most rare, in addition of a hypertonic solution containing both sodium and water, but the proportion is not normal. This is probably more linked to some sort of IV solution that's given in the inappropriate levels. Again, manifestations are listed in Table 8.4, and the more rapid the increase and the larger the volume of sodium, the more severe and rapid the effects are going to be. All right, normal functions for potassium. So we're going to move into potassium for just a moment here, and then I'm going to talk about the regulation for both sodium and potassium. So Normal functions of potassium. Notice this whole page is filled with the normal functions of potassium. Hugely important. Maintains the osmotic integrity of the cells. It's the ion inside the cell. Remember, sodium's outside, potassium's in. It's a buffer in terms of maintaining pH. This is really important. It plays a significant role in the kidney's ability to concentrate urine. If you are lacking potassium, your urine will be dilute and you'll lose fluid. You need it to grow. Many enzymes require it, particularly in protein synthesis and carbohydrate catabolism. This is our metabolism. And key here is its role in regulating membrane potential. So we talked about sodium as being the depolarizer. Well, here's your three functions of potassium in terms of neuron function, action potential function. First of all, it regulates resting membrane potential. That's a key factor in function. So when I say regulates membrane potential, a decrease in potassium or hypokalemia will cause the membrane to become more negative, and therefore you have hyperpolarization. An increased hyperkalemia causes the membrane to become more positive, and that's hypopolarization. So I kind of tell you students to kind of think of it this way. If you're hypokalemic, you'll be hyperpolarized. So if you're hyperpolarized, you're going to need a greater stimulus now to reach threshold, open sodium channels, and make an action potential. Let me say that again. So if you have hypokalemia, low potassium, you have hyperpolarization, it's more negative. You need a greater stimulus to reach threshold, open sodium channels, and initiate your action potential. If you have hyperkalemia, meaning a lot in excess of potassium, and the membrane becomes more positive, you are hypopolarized. It takes less of a stimulus now to reach threshold, and therefore sodium channels, the action potential, will open more rapidly. Now, here's the really tricky part with this one. Although that last statement I said is true, that you will have hyperkalemia leads to hypopolarization and more excitability, these channels, these receptors will actually not be able to sustain rapid depolarization. So you'll have this initial increase in activity, but then you will actually find that you have inactivation of sodium channels, and it actually results in a decrease in excitability. So initially, potassium levels rise and you get this excitability, more rapid action potentials. But after a very short period of time, the channels become exhausted. They cannot continue to fire at that rate, and therefore they just shut off. They won't respond at all, and you actually have a decrease in excitability. Hugely important in terms of how potassium levels function and why potassium has to be so narrowly regulated, because we are talking about excitability, for instance, at the heart. And so if potassium levels rise, we initially have a rapid heart rate, we'll have a tachycardia, and then the channels will exhaust and the heart will literally stop. So potassium's role in the resting membrane potential is key. The rate of repolarization is also affected. So low potassium means it takes longer to repolarize. High potassium, and we repolarize faster. Again, possibly speeding up action potentials, but then leading to that same exhaustion. And you also have to have potassium to open channels in the first place. So if there's no potassium, sodium channels won't even open to depolarize. So our regulation, as I mentioned, we would take a look at this regulation. Aldosterone, I've already mentioned it, is your regulation for sodium. Here it is also as your regulation for potassium. Its job is to delete potassium. You also have at the kidneys what's called the potassium hydrogen exchange. So you can, because both have a single 1+ charge, particularly at the kidneys, they can switch places. So if potassium levels are starting to get too high in the blood, we'll switch them out. We'll get rid of potassium and send it out in the urine, and we'll keep hydrogen. We'll equal charges, we'll switch. The problem is, of course, if I keep hydrogen, hydrogen affects my pH. My pH can start to drop. So it's a good exchange, but it can affect pH. And you also have what's referred to as the ECF-ICF shifts. Again, because we have to so closely regulate potassium, you can see these shifts between the ECF and ICF. And so this happens primarily in red blood cells, muscle, liver, and bone cells. So in this process, you can have the cells shift places. So again, it's a potassium hydrogen shift, so it will affect pH, but you can move potassium in and out of the cells depending upon changes in concentration. So this process can be altered by, in other words, this process can happen if we have an increase in serum osmolality, so we have a more concentrated fluid. In acidosis and acidotic states, you'll see this happen. Increased in epinephrine, norepinephrine, and acetylcholine can cause this, and excessive exercise can lead to these kinds of shifts that occur. So, important concept, please read about this in the book as well. So, here are our conditions. Hypokalemia is a low potassium level, usually inadequate intake or some kind of loss through the kidney, skin, or GI tract. And again, that transcellular shifts, and that's really referring to this shift right here. So the shift in reaction to, say, acidotic states can change potassium levels. So these are the causes. Manifestations are in Table 8.5. Again, there's a bunch of them, but here's a couple that are really important. You will see weakness of muscles, paresthesias, a burning or tingling sensation, smooth muscle activity slows. The effects on the cardiovascular system can be key problematic. Look at what happens in the ECG or EKG, figure 8.12. You do need to know the changes there, and recognize that the kidneys will try to conserve them. So lots of manifestations. Again, think more about what its normal function is for potassium, and then these make a lot more sense. We have problems with action potentials. That leads to this low activity because we cannot initiate our action potentials, our muscle contractions. Hyperkalemia is a decrease usually in renal elimination. It's the most common cause. That we're usually dealing with some kind of kidney failure as the primary problem that we're dealing with here. So it's something wrong with the kidneys. There can be the shift again between the ECF, ICF, between the cells in the ECF and ICF. Excessive rapid administration, that's more in a healthcare setting. And if we have a large amount of cell death, burns, for instance, can be one in which we can see a real problem with hyperkalemia. Manifestations, again, are in Table 8.5. Symptoms are really similar. Remember, because what I said the function is, initially you'll have this rapid beat and then everything slows down. So really the manifestations between hypo and hyperkalemia are very similar. I don't ask a lot of questions about that in comparison then, because I'm really more interested in you knowing the normal function. And that's the end of this lecture. We'll get on with other electrolytes